All right, welcome everyone to this high-yield explainer on migraine pharmacology. I am so glad you're joining me today. We're going to treat this as a focused, exam-oriented board review lecture. So if you're looking to absolutely ace your exams and master that massive 25-mark long answer question on migraine pharmacotherapy, you are in the exact right place. Let's dive in.
Here's a quick look at our roadmap for today. We'll be moving through introduction and pathophysiology, serotonin receptors, acute therapy, recent advances, prophylaxis, and then we'll wrap up with exam pearls and a summary.
Starting off with Section 1, Introduction and Pathophysiology.
So why exactly does a migraine produce a severe, unilateral throbbing headache, which is often preceded by an aura, and accompanied by awful things like nausea and photophobia? And more importantly for us, how do our drugs actually intervene? For decades, we thought of this merely as a vascular headache. But today, the crucial thing you need to remember is that we absolutely must frame the migraine as a complex neurovascular disorder.
Examiners absolutely love this step-by-step pathophysiology pathway, so please commit this sequence to memory. It all begins with a trigger. This trigger causes cortical spreading depression, which is essentially an abnormal, slow-moving wave of neuronal depolarization. This leads directly to the activation of the trigeminal system. Once activated, these sensory fibers release incredibly potent vasoactive neuropeptides. The most notable one, CGRP, or calcitonin gene-related peptide, alongside substance P. This massive release causes profound neurogenic inflammation and major vasodilation of the cranial vessels. And it's that intense vasodilation and inflammation that the brain perceives as that classic debilitating throbbing pain.
Moving on to Section 2, serotonin receptors.
Now, while serotonin receptors are broadly classified into families like 5-HT1, 2, 3, and 4, for migraine pharmacology, we must zoom right in on the 5-HT1 pathways. Notice the distinct roles of these subtypes. You've got to note these high-yield targets carefully. Activation of the 5-HT1B receptor, which is located on vascular smooth muscle, causes cranial vasoconstriction. Meanwhile, activation of 5-HT1D, located on nerve terminals, inhibits the release of our inflammatory CGRP. But pay special attention to 5-HT1F. These are located on trigeminal sensory neurons. Activating them inhibits pain transmission, but crucially, it does not cause vasoconstriction. Keep that 1F receptor in the back of your mind. It's going to be a huge deal when we talk about newer drugs.
Which brings us to Section 3, acute therapy. It is vital to contrast the stepwise treatment approach here. For a mild to moderate attack, we start simple. We're talking NSAIDs like ibuprofen, aspirin, naproxen, or paracetamol. We often combine these with an antiemetic like metoclopramide or domperidone, which handles the nausea and actually helps improve the absorption of the painkiller. But if the patient presents with a moderate to severe attack, actually scratch that, even if they just fail the simple analgesics, we escalate straight to our gold standard specific abortive agents, the triptans.
Triptans, such as sumatriptan, rizatriptan, and zolmitriptan, have completely revolutionized migraine care. They are selective 5-HT1B and 1D agonists. So recalling what we just learned, this means they do two things. First, they decrease the release of CGRP via that 1D receptor. Second, they cause cranial vasoconstriction via the 1B receptor. But listen up, because this is the absolute highest yield exam fact of the day. Because they constrict blood vessels, they can cause chest tightness, tingling, and even coronary vasospasm. Because of this, triptans are strictly contraindicated in patients with ischemic heart disease, a history of stroke, or uncontrolled hypertension. Never forget that.
We also have to briefly mention the ergot alkaloids, like ergotamine and dihydroergotamine. These were much older drugs. They act as partial 5-HT agonists and are extremely powerful vasoconstrictors. While they're historically important, they are rarely used today. Their adverse effect profile is just significantly worse than the triptans, causing severe peripheral vasoconstriction and terrible nausea.
All right, let's look at Section 4, recent advances. First up in our exciting new frontiers are the gepants. Think ubrigepant, rimagant, and atogepant. Remember that powerful vasodilator, CGRP, from our pathophysiology pathway? Well, gepants are small molecule CGRP receptor antagonists. They just directly block that CGRP inflammatory pathway. And the best part, because they don't work by constricting blood vessels, they offer a brilliant, safe, acute alternative for patients who have cardiovascular risks and absolutely cannot take triptans. Next up, we have the diptans, specifically losmetitan. Remember that 5-HT1F receptor I told you to keep in the back of your mind? Well, here it is.
Lasmiditan is a highly selective 5-HT1F agonist. It's highly lipophilic, so it crosses the blood-brain barrier easily, and it inhibits trigeminal pain signaling. This brilliantly illustrates the beauty of targeted pharmacology. Because it lacks affinity for the 1B receptor, it causes absolutely zero vasoconstriction. It's a literal game changer for cardiovascular patients. Just be aware, you do have to warn patients about CNS side effects. Things like dizziness and sedation are common. In fact, patients are advised not to drive for about 8 hours after taking it.
The third major advance involves monoclonal antibodies, or MBAs. We're talking about drugs like galcanezumab, fremizumab, and eptinezumab, which bind directly to the CGRP molecule itself. Then there's aronumab, which binds to the CGRP receptor. Given mostly via subcutaneous injection, these modern targeted biologics utilize incredibly long half-lives to just consistently block the CGRP cascade. This completely redefines long-term preventative care. We're basically replacing daily prophylactic pills with monthly or quarterly injections.
And that transitions us perfectly into Section 5, Prophylaxis. While those CGRP monoclonal antibodies are the shiny new kids on the block for prevention, for your exams you absolutely must know the classic, established oral options. These are indicated for patients suffering from frequent migraine attacks. These are actually drugs repurposed from other conditions that just happen to have proven efficacy in reducing migraine frequency. Note these 4 major classes: beta blockers like propranolol, anti-epileptics like topiramate and valproate, tricyclic antidepressants like amitriptyline, and calcium channel blockers like flunarizine. Make sure you can easily list these out on your exam paper.
Let's bring it all home with Section 6, Exam Pearls and Summary.
I want you to take a mental screenshot of this table right here. It is the ultimate comparison guide, and it beautifully illustrates the therapeutic landscape. Triptans, 5-HT1B/1D agonists used acutely. Diptans, 1F agonists used acutely without vasoconstriction. Gepans, small molecule CGRP antagonists for acute use. And MBs, large molecule CGRP blockers for prevention. Seriously, practice drawing this exact table out. It will absolutely secure your marks. Okay, let's do some active recall. If an examiner asks you this Viva question, I want you to confidently recall that triptans are 5-HT1B and 1D agonists. And because that 1B activation causes vascular smooth muscle contraction, there is a very real, very dangerous risk of coronary vasospasm. That makes them completely contraindicated in ischemic heart disease. How about this prompt? Use this to quickly recall the newly approved gapants for acute attacks and those monoclonal antibodies for prevention. And of course, don't forget to quickly rattle off your classic daily oral prophylactics, your beta blockers, your anti-epileptics, and your antidepressants. Let's end with this rapid revision summary to really cement what we've learned. Migraine therapy targets serotonin and CGRP pathways. Triptans are the main acute drugs, while beta blockers, anti-epileptics, and newer anti-CGRP drugs are used for prophylaxis. As you review your notes today, I want to leave you with a thought. In a future that is increasingly dominated by these incredibly targeted biologics, do you think non-specific therapies like NSAIDs and even triptans will eventually become obsolete entirely? It's a fascinating evolution to watch. Thank you so much for joining me in this explainer. Study hard, and I'll see you in the next one.